Faria. Assalamu alaikum everyone, and a very good morning. And inshallah we will have Ramadan tomorrow, so Ramadan Kareem to everyone. May this month bring the blessings and health to you and your family, inshallah, and the rest of the world, inshallah. So for the next hour or so, we will talk about the inner ear. Can you all hear me?
Yes, doctor, we can hear you.
Beautiful. So you can hear me. That's great. Where is the chat box? Can I see the chat box? Chat box. Yes, so you can see me clearly. So I'll open this chat box next to me so I can see what is happening. All right. Now you can see that we talked about the external ear. We talked about the pinna. We talked about the external auditory canal. Then we talked about the middle ear containing bones which are articulated with each other from malleus, incus, and stapes. And then the foot of the stapes is sitting on the oval window. Now, oval window would, as if it is taking us to the inner ear. All right, the oval window will take us to the inner ear. Now, remember that this is the tympanic membrane, and this is the most, central part of it, which is the most concave part of it. And this is the point which is called an umbu, and this is where the handle of the malleus is attached. Okay. Now, one of your colleagues asked me about what is the function of tensor tympani and tensor palatini. So, tensor tympani is the muscle which will be sitting there, and when that muscle will be constricted, it will pull this part of the bone and will make the tympanic membrane rigid. Like the muscle, stapedius muscle, when that muscle is constricted, it will pull the foot plate of the stapes off from the oval window. So what will be the end result of both these muscles? So you will have constriction of all these bones and they'll become rigid. So the sound waves which are striking the tympanic membrane will not oscillate these bones. Hence, they will not convey the sound waves into mechanical waves further down. Does that make sense? So we will have the reduced sound intensity. Okay. Now let's look at the parts of the inner ear. Now, inner ear is interesting, which has an anterior part, which is a cochlea, and it has a posterior part, which is a vestibule and semicircular canal. Okay. Now, cochlea is for hearing, while the vestibular part and the semicircular canal part is for balance. So when do we try to achieve the balance? During motion or during a static position. So we want to keep our head in certain position, so we know where our head is in space. So detecting that, detection of that sense would help us figure it out that where we are in space. Okay. Now let's look at what are the different parts of inner ear. Now, inner ear is basically divided into, you can study it in two ways. It has a bony labyrinth. What labyrinth? Have you ever seen a labyrinth where kids play and go and then get lost? Okay. Have you ever seen such games like maze? Yeah, it's a maze. People get in and then they're trying to find out the way from the other end. All right. Sometimes you get lost. Now, we have a bony labyrinth and we have a membranous labyrinth. But interestingly, I want you to understand the difference between the two and how does it work. Do you see the difference between a mold and a cast? What's the difference between a mold and a cast? Mold and a cast. Mold is a cavity. Beautiful. Mold is a cavity, and the cast is something which will tell us the shape of that cavity. That makes sense? So like mold of a cake or mold of a jelly that you cook, and then once you remove the mold, you will have a jelly of that particular shape. Okay? So cast is something which is reciprocal of the mold. Okay? Allah, you see that if you cook the jelly, if you put the jelly in a simple rounded bowl, when you take it out, the jelly will be rounded. If you put it in a square plate, it will be like in a square plate. If you put it in like in a cone, it will be shape of a cone. So cone is a mold, and cone shape of ice cream is a cast of it. Does that make sense? You see that? Yeah. So maize is a pan of the cake, and the cast is the cake itself. So once you remove it, okay. Now let's look at, if I ask you, have you ever visited a cave? Have you ever visited any cave? A cave in a mountain? Yes, no? Think hypothetically, as if you are going around and visiting a cave system. All right. Now, if I asked you to bring a piece of cave, can you do that? Bring a piece of cave. Can you do that? We can't, because the cave is the space in the mountain itself. So you can bring a piece of stone, but not the cave. You cannot bring the cave unless what you do, like you would fill that cave with a cake, bake it, and bring it out. So the cake will be shape of the cave. Or you fill it with a balloon and freeze the balloon and take it out. You can take that out, but you cannot bring the cave out. That makes sense? With this, if I ask you, do not look at all these levels now. Area there, which is in the petrous part of the temporal bone. Can you see all these spaces? Can you see all these spaces? Yes, no? Now this is where the bony labyrinth is, and this is the bone. You see how rock hard it is? This is the petrous part of the temporal bone, and within the petrous part of the temporal bone we have these spaces. Okay, so we can see we have a space number 9, which is this area, which is the middle cavity. Okay, this is the area where we have the mastoid antrum and the mastoid cells there. Okay, you see this one window there? What is the shape of this window? Oval. So we call it as an oval window. Okay, similarly we will have a window there. Okay, this window as a shape like round, so we call it as a round window. Now this space is the middle ear, and from there we can then enter into the inner ear. Can you see this number 14 there? Can you see this space there? This is the space where we have the cochlea sitting. Okay, now these are those spaces which are lined by membrane. Which are lined by membrane, as if these are all the caves. Caves are lined by the membrane, and so we have a bony labyrinth, and then we will have a membranous labyrinth. If I ask you to take one out, which one you will be able to take out? Bony labyrinth or membranous labyrinth? Excellent. So you will be able to take out or dissect out it's a very difficult dissection. So you can remove the membranous labyrinth. That makes sense? Okay. Now with this understanding, you can now see that this is where we will have our what? Remember that we have external auditory canal, which has a cartilaginous part and the bony part. This is where it will be, and then it will take us to the limit there. That's where we will have the bony groove for the tympanic membrane. So this area would be there of the external auditory canal. This is the area of the middle ear, and inside this we will have the area of the inner ear. Can you see this number 13 structure? This is a structure which is showing us, this black probe is showing us as if the course of facial nerve. So you see that facial nerve is passing through that bony canal, which is sitting in the middle wall of the middle ear cavity. That makes sense? Similarly, we have this opening, which is the chorda tympani. Okay, this number 9 is for the chorda this probe, which is sitting there. Okay, so number 13 and this probe, which is representing the chorda tympani. Okay, doesn't make sense? Now I want you to look at this one. Now this is the bony labyrinth, which is this area, and this is all the membranous labyrinth. This light gray thing that you see is all the membranous labyrinth. So you can see the cochlear duct there, which continues into the saccule and the utricle and the semicircular canals. Okay, that makes sense? Are you all following me? Good. Now this is where it will be. So when you take it out, you will see what? You will see this membranous labyrinth. Okay. Now membranous labyrinth will have a cochlear duct, a saccule, utricle, and these semicircular canals, and all these are connected with each other. You see that they're all connected with each other. So if you look at the cochlear membranous labyrinth, it continues with a saccule through this canaliculus of reunions, which is connecting the cochlear part into the vestibular part, and the vestibular part are connected with these semicircular canals at the utricle. Okay, does that make sense? Now what you see here, you see when you look at these bones in the lab, you see some of these bones in the lab which are basically fake. You cannot dissect out such a bony thing out from the skull. Okay, you cannot do that. So in the lab that you see the models of the ear, they are basically showing you a kind of, fake bony labyrinth, which is very smooth and stuff like that. You see that this is all bony. Actually, this is the one which is a grayish structure, which is the membranous labyrinth that you see inside the inner ear. Okay, that makes sense? Now let's look at the inner ear. Now inner ear, as we talked about here, so we will look at the membranous part. So we'll look at the cochlea first, and then we'll look at the vestibular and semicircular canal part. So if you look at the cochlea, so now I'll show you with the help of the diagram as well. So this is just a quick run that what we will be looking at. So if we look at the length of cochlea, it's around 30 millimeter long a tube. Okay, it's a 30 millimeter long a tube, and it is sitting like a coil. Okay, we talked about the coiled nature of the cochlea, so we will see how it is. Now it is not a complete 3 circles, so it is 2 complete and 3/4 of the third. It has 3 compartments: scala vestibuli, scala tympani. Both of these will have perilymph, and scala media, which is also called cochlear duct, will have endolymph. Okay, now this endolymph and perilymph, the endolymph is like intracellular. Okay, this endolymph is like intracellular. So what is the level of the potassium in intracellular? High or low? Intracellular fluid, what is the level of the potassium? High or low? High. What will be the level of the sodium? Low. Opposite would be the case of the perilymph. So the perilymph is basically between the bone and the membranous labyrinth and these 2 parts of the membranous labyrinth. Okay. Now the other bony landmark that we will see is the modulus, which is a central core, central core of the cochlea, which is directed to the internal acoustic canal, and it transmits the 7th nerve. The 8th nerve. Okay. Also, it has vessels to the cochlea, while the apex of the cochlea is facing towards the tensor tympani muscle. Now, osseous spiral lamina, I'll show you how it is a thin bony plate which is winding round, the modulus like a screw, and it is attachment for the basilar membrane. Okay, and it divides the bony cochlea into 3 compartments. Then we have this canal, Rosenthal canal, which is housing the spiral ganglion. Then we have these 3 compartments, scala vestibuli, media, and tympana, the uppermost, the middle, and the lowermost. Okay. Now this uppermost will be closed by the oval window, where the footplate of the steppiece is, and the lowermost will be covered by the round window, and I'll show you how. Promontory is the basal coil. The first coil of the cochlea is called the promontory. You remember the promontory was projected into the middle ear. Then we have the round window, and now I'll show you how these things look like. All right. Look at this screw first. That's where its base is. That's where it is center, and these are the threads of the screw. Can you all appreciate this? Can you all see the screw? Don't look at this cochlea now. Can you all see the screw there? It is like a spiral ladder. It's like a spiral ladder. This little girl is coming down. Okay, and this is also like a spiral ladder. Now, if you look at the same screw sitting right in the center there of the cochlea, that's where we call it as the modulus, which is a central part there. And these threads of the screw, which are the spiral lamina, that's where the spiral lamina, which are the threads of the screw there. Attached to the spiral lamina, we have this membrane, which we call it as the basilar membrane. Now, basilar membrane is like our steps of the, so as if you walk up on the basilar lamina. Okay, so you'll keep going up all the way to the apex there. Does it make sense? Are you following me? And somebody has his or her microphone on. Are you all following me? The way that this screw, a spiral ladder, and this cochlea is working. Okay. Now, if you look at this cochlea, which will have 1, 2, and this last twist. In the cochlea, the bony cochlea, we will have these 3 canalicular system, scala vestibuli, scala tympani, and sitting in the center, we'll have scala medial. You see that they will be coming and turning around, coming and going around up. Okay, so it's like a worm or the snail which is going around in a circle. In the center, we will have the bone, and in the center of the bone, we will have the ganglion of the cochlear part of the vestibulocochlear nerve sitting. Okay. Now, if we look at all 3 of these turns, this is how they will look like. So if you are running here, you will come out from there, and then you will ascend up there, and you will come out from there, and you will be going up. So you see that from here, you can go all the way up to the apex of the modulus. Does that make sense? Does it make sense? So when you go in the lab, make sure that you look at the bony labyrinth. They will show you, and cochlea is organized. Okay. Now, if we make these 3 tubes straight, if we unwind these, this is how they will look like. So scala vestibuli will go from the base all the way to the apex, and from this point it will continue into the scala tympani. Now, this continue is called as the helicotrema. This is called as the helicotrema, and you can see that the scala vestibuli will continue into the scala tympani. Now, what is forming the window at the beginning of the scala vestibuli? It's an oval window, and we have the steppiece there at the oval window. Now, if we move the steppiece, what will happen to the fluid, which is the perilymph in the vestibule? What will happen to the fluid? Are you guys with me? Are you guys with me? We have 148 people. If we move the foot plate to and fro like my arrow, which is like a piston, Have you seen the syringe and the plunger of the syringe? So if you move the plunger of the syringe, what will happen to the pressure inside the syringe? Now, if we move the foot plate of a stapes, it will create a difference in the pressure. So if we move the foot plate of a stapes, if we move, so if you take a syringe, put it in the water, and then you move the plunger of the syringe. So you see what will happen to the fluid which is sitting in the syringe. So that fluid will start moving within the syringe, okay, because of the movement of the plunger. Now this would cause the movement of the perilymph. The perilymph movement will continue into the perilymph of the scala tympani. And that's where we have the round window. The round window will be covered by a membrane, which we call it as a secondary tympanic membrane. That makes sense? So if we move the fluid from here, the movement of the fluid will continue and will come and will die at this end. So if we create a wave, of the movement, it will come all the way there, and this round window covered by the tympanic membrane will bulge out. When you pull this plate back again, this tympanic membrane will go inside again. So if you create a pressure, a positive pressure wave, it will go from the scala vestibuli into the scala tympani. Does that make sense? You will learn more about it when you will learn the function of the cochlea. Okay. Now, while we are doing this, while there is a movement of the fluid in these two compartments, the fluid which is sitting in the scala media will also move. Okay, that will also move, as if you take a jug full of water and put a little tennis ball in there. So if you move the jug, the water will move. If the water will move, the ball inside will also move. That makes sense? So you are moving the jug only, then the water is moving, and that movement of the water is moving the ball which is sitting inside the jug. It's like an ice cube as well. Does it make sense? Is it making sense? Now if you look at the scala media, remember we talked about the spiral lamina. I'll show you there once again. Spiral lamina and this membrane which is attached to the osseous, which is bony spiral lamina. It is narrow there, and you see how wide it is become towards the apex. So this basilar membrane is very narrow at the base, very wide at the apex. I'll show you here once again. So you see at the base it is narrow and it is very wide towards the apex, and this is the helicotrema. You see, so it's not completely sealing off. This basilar membrane is not going all the way there, so it is not sealing off this gap. So this gap will make the movement go from the scala vestibuli into the scala tympani. The fluid movement of the perilymph will continue. Now, while this fluid is moving, this will also move the basilar membrane. Now, basilar membrane, it's not only narrow there, but it's also thick. So it's a narrow and stiff. While towards the apex, it is wider and less stiff. Wider and less stiff. So if it is narrow and stiff and less stiff there, which sound waves, high frequency or low frequency, would be able to move the base? High frequency sound, because high frequency sound will be more powerful. That's why they can move the stiff. It's like if I ask you to move a carpet, you move a towel, and you move a tissue paper. Which one is really easy to move? A carpet, a towel, or a tissue paper? obviously the tissue paper will be easiest mode. Hence, the tissue paper there, which is very thin, easy to move. Carpet over there. Does make sense? Hence, a carpet will be difficult to move. Now, if we see what is sitting on the basilar membrane, so we'll see the cochlear duct. We talked about the spiral ligament, basilar membrane, which is a fibrous membrane, resonance membrane, and organ of Corti. And I'll show you what is the organ of Corti. What is the tectorial membrane? Okay, tectorial membrane is arising from the upper lip of the limbus, and it forms the overlying membrane of the organ of the Corti, and it is composed of collagenous fibers, and we'll see the tunnel of the Corti. This is how it will be. Okay, now let's look at, you're looking at the cochlea. Okay, you see the trunks of the cochlea. Now, if you make a section of just one of these, you see 1, 2, and 3 such tubes which are running all around. So we have the scala vestibuli, scala tympani. They will continue with each other at what point? They will continue with each other at the apex there, which is the point of the helicotrema. In the middle, we have cochlear duct or scala media, which contains the endolymph. Now, if you enlarge this area there, which is forming the organ of the Corti, that's where you see these different hair cells. Okay, now this is the tectorial membrane. Okay, this is that gelatinous substance-like structure. Okay, which is coming from the osseous spiral lamina, and this is where the basilar membrane is also attached. You see that? This is where the basilar membrane is attached. This is the modulus, and that's where we have the spiral ganglion sitting, because the modulus is sitting in the center, and this ganglion is going like circularly, hence we call it the spiral ganglion. Okay, now if you look at the organ of the Corti, it will have receptor cells. We call them hair cells. In our cochlea, we have hair cells, and all the other places we have these hair cells. Now we have inner and outer hair cells. Inner and outer hair cells. Now, inner cells are supported by these cells, which are phalangeal cells, which are supporting each cell completely. So now if I ask you how many cells you see in the outer layer and how many you see in the inside. Inner hair cell, how many inner hair cells you see? 1. Now, inner hair cell, we have 1 line of inner hair cell, while outer hair cell, we have 3 lines of cells. Okay, so inner is 1, while outer hair cells are 3. Okay, and if you look at the supporting cells, these supporting cells are not completely surrounding. Look at these hair cells there. They are completely surrounded by the supporting cells or phalangeal cells, unlike the outer hair cells. And you look at these nerves, which are the afferent nerve fibers, they are synapsing onto these hair cells. Okay, now if you look at the histological version of it, you can see the basilar membrane there. Okay, you see the basilar membrane there, and you see the inner hair cells, which is single layer cell, while the outer hair cells, which are 3 lanes, which are sitting outside. Okay, in between we have a tunnel. We have this tunnel of Corti, which is between the inner and outer hair cell. Now, all these hair cells and the supporting cells are sitting on the basilar membrane. If you move the basilar membrane, what will happen to the hair cells? They will also move. Now, interestingly, these hair cells will have these cilia-like structures which are projecting out from the apical surface. Now, they are buried in this gelatinous substance. So what happened? The cilia are buried. If you move the base of the cell, the cilia and the body will go in different directions. And this movement of the cilia in one or the other direction will create an action potential. This movement, which is basically responsible for the movement of the potassium inside the cells, will create an action potential, and that's where these nerve endings will have their stimuli. That makes sense? Look at these cells here. So if you look at the organ of the Corti, which includes the tectorial membrane, which is this gelatinous substance-like supporting cells, which are called the phalangeal cells. Okay, inner hair cells, which is a single row, tunnel of Corti, and outer hair cells, which are 3 to 4 layers, cochlear afferent and efferent, and basilar membrane. So these are the components of the organ of Corti, while the hair cells are embedded in the tectorial membrane, having 50 to 150 stereocilia, which are microvilli. They are not cilia-like structure. They are stereocilia, so they are more like microvilli. Okay. Now let's look at the inner hair cell. Now inner hair cell, if you see, it's like a flask shape. Okay. Someone is asking, Hania is asking, I don't understand what causes the change to potassium to cause action potential. Now you see, it's a movement of, you look at this, minus 70 millivolt is the, what you call it as a electric current in the cell. Now movement of the ions across the membrane will change. The movement of ions across this membrane will change the electricity in the cells, and hence will cause the action potential in these afferent fibers. Okay, you learned about the action potential in cardiac muscle and muscles and everywhere. That's where the changes of the potassium and sodium. So sodium comes in, potassium goes out. That's where the movement of the positivity and negativity, and that's where we generate the action potential. Look at the outer hair cells. Now you see that the movement of this tectorial membrane, you see that if we move the basilar membrane, the tectorial membrane would be there. So movement of the tectorial membrane and the basilar membrane will cause these hair cells follicles to move. The movement of these will cause the movement of ions across the membrane, which you will learn in your physiology, that how these electrical activities are achieved. Okay, so you will learn in your physiology. That makes sense? So your outer inner hair cell supported by the pillar cells and phalangeal cells. Okay, different books will name them differently. So if you remember these are the supporting cells, that will be good enough. Okay. Now if you look at the innervation of the hair cells, this is where the spiral ganglia, you remember the vestibulocochlear nerve. Most of the innervation is coming from the inner hair cells. Only some is coming from the outer hair cells. So most of the nerve that we see, the cochlear part of the vestibulocochlear, it is coming from the inner hair cell. Now any change in the ion concentration of the fluids of the perilymph or endolymph will affect what? Will affect the electrical activity of these hair cells. Hence, any medication which affects the potassium level and the sodium levels in your inner ear will affect our hearing. So some of the drugs that you would know that they are ototoxic. They are ototoxic because they change the concentration of these ions in our endolymph and perilymph. Now, if you look at the vestibule, which is now detecting the motion, so you understand what are the most important cell of the cochlea. If I ask you, name one important cell of the cochlea. Obviously, hair cell. Okay, so hair cells are our mechanoreceptor. So you move them. It's a movement of these hair cells which will cause electrical activity. So these are mechanoreceptors. Okay, now similarly, these mechanoreceptors are present in other areas which will detect the motion. So we have linear and angular motion. For the linear motion, we have the saccule and utricle. Like we have inner and outer hair cells sitting on the basilar membrane, we have the maculae there. For the linear motion in saccule and utricle, while in the semicircular canals, which are 3 in number, anterior are superior, posterior and horizontal. The other name of the horizontal is lateral. So anterior are superior, posterior, horizontal are lateral, and they have crista. And I'll show you how do they. So if you look at, this is that saccule, and this is that utricle, we are looking at the membranous labyrinth now. Remember that we are looking at the membranous labyrinth, and these are those semicircular. These are those semicircular canals. How many semicircular canals we have? 3. How many openings they should have in the utricle if they are opened by 2 openings? There should be 6 openings. But interestingly, there should be 6. But interestingly, there are only 5. Why there are 5 openings only? Because 2 of them join together. Okay, 2 of those semicircular canals are joining together. Okay, and we will see that what are those. Okay, does make sense? We have the semicircular canals. Look at these semicircular canals which are joining together. So instead of having 2 separate openings, we have 1 opening there. So 1, 2, 3, 4, 5 instead of 6. Does that make sense? So now these nerves will, these areas will be innervated by the vestibular part of the cochlear, vestibulocochlear nerve. Okay. Now let's look at the vestibule. Now vestibule, we have the saccule and the utricle. The saccule and the utricle, and within the saccule and utricle, we will have what we talked about earlier. We have macule. Okay. Now macule will have those hair cells. Okay. So let's look at what is the macula. They are located in the utricle and saccule. In utricle, they are in the floor, while in the saccule, they are sitting in the posterior wall. So let's look at the in the floor of the utricle and in the posterior wall of the saccule. Okay. Now they are embedded in a gelatinous substance. They will have these same hair cells surrounded by the supporting cells, and their hair cells, hair bundles, are embedded in this membrane, which we call it as an otolith membrane. Okay. Why we call it otolith? Because it is formed by the calcium carbonate. Okay. Underneath that, we have a subcapsular meshwork, which is like, connecting these projections of the hair cells. Now there is a virtual line, which is we call it the styrolia. That's a difficult word for me to pronounce. Styola. Now, styola is not a structure itself. It is the way that it is the different hair cells are looking, the way that they are sitting. For instance, if I put these 3 fingers and these 3 fingers, you see that the way that they are looking different. So if all these 3 fingers of many hands, if I put next to each other, you will see towards the little finger there will be kind of a valley. Towards the middle finger, it will be like a peak there. Okay, while there is no valley, it's just because of the way that these hair cells and their projections are. Okay, we call it styrola. I'll show you here. This is where this styrola is. Okay, now this is nothing but is basically the direction of these hair cells. It's just the direction of the hair cell. So if you look at the macule of the utricle, we will divide it into a medial and the lateral part, while that of the saccule we divide into a ventral and the dorsal. So ventral, which is at the front, and the dorsal at the back, because the macule of the saccule is standing vertical, while that of the utricle is sitting horizontally. So we divide into a medial and the lateral compartment. Okay. Now this is how, if you look at the schematic diagram, this is how they will be sitting. So if you look at the macule of the utricle and macule of the saccule, the utricle is sitting like horizontally, and this is sitting vertically. Okay. You will learn about how do we detect the motion, that which side our head is moving. Okay, in a linear motion. So is it going vertically up or down or forward or backward? So you see that we have vertically up and down, forward and backward movement detectors. You will learn in your physiology. Now, if we look at the semicircular canals, how many semicircular canals we have? 3 semicircular canals. So we have three semicircular canals. We have superior, posterior, and lateral. Now the superior and posterior, they join together. Okay, so superior and posterior join together and open by one opening, while the other, which is the lateral, it will open by its two separate openings. Now each duct, each semicircular canal will have a dilated part, which we call it as the ampulla. Can you see this dilated part of the duct there? Yes, Abdullah, we have semicircular canals, 3 on each side. We have inner ear on the right and inner ear on the left side. So anything that I'm talking about, they are sitting bilaterally. Okay, they are sitting bilaterally. Can you all see it? The dilated part there. So 1, 2, and 3 dilated parts which you can see. We have 3 semicircular canals, and each canal, when it is joining the vestibule, contains the receptor organ cristae. So ampulla is a dilated part, and this ampulla will have a crista. Like we have macula in the saccule and utricle, we will have a crista in the semicircular canal. And the semicircular canals are helping us to detect what? Angular motion. Okay, if we are going in circles, we will know that which position of my head is. Is it going from left to right and back and right and then forward and on the left? Okay, so which direction am I rotating, upside down or from side views? So that motion is detected by semicircular canals, like in vertigo, like merry-go-round. And that's why if there is a problem of the semicircular canal, we will see that patient will be complaining of vertigo, as if my head is going on one side. Well, it's not going on one side. You are perceiving that your head is going on one side. Okay, that's where these problems. Beautiful. Now let's look at the cristae, like we saw the macule. Now they are located at the ampulla, which is the dilated end of these 3 semicircular canals, and that's where the bony thing which is elevated. Okay, that's where this vestibular part of the vestibulocochlear nerve. Now this crista, which is the elevation, will have this. Similarly, we will have what cells? What cells we will have here? Hair cells. Excellent. We will have hair cells. Now you see that the hair cells are what? They are mechanoreceptors. So what do they will detect? They will detect the motion. Okay, so what we have inside the inner ear, which we are moving the fluid inside the inner ear. So remember, in cochlea, we move the perilymph from the scala vestibuli into the scala tympani. Okay, scala from one side to the other, and that's where in the middle part, the duct which will move. So we move the fluid. Okay, now what is happening in the semicircular canal? Semicircular canal will also have that fluid inside. Okay, now these hair cells are buried in gelatinous substance, which we call it as cupula. Like we have otolith, now we have the cupula. Now the cupula functions as a watertight partition. So you see that nothing will go from this semicircular canal into the saccule there. Why not? Because this is the watertight junction. You see that, so they go all the way up to the bony point there. So from the bony point there, all the way bony point there. So we're looking at the cross section. All right, let's see this part there, which is the. Look at this area there where the crista is located. It is completely sealing off the communication of the semicircular canal into this vestibule. So if there is a fluid there, it won't be able to come into this side. Okay, why not? Because this crista is completely sealing it off. It's a watertight junction. So the movement of the fluid there will displace this scapula, If you displace the capula, if you move the capula, water won't go from one side to the other, but the hair cells will move. If we move the hair cells, what will happen to the electrical activity? What will happen to the electrical activity? We will generate the action potential. And if we generate the action potential, then these nerves will have the impulse. That makes sense? So what basically we are trying to achieve in a cochlea and vestibular and semicircular canal system to move these mechanoreceptors, which are hair cells. What is the microscopic structure that we are trying to move? We are trying to move their cilia, which are basically the microvilli. Well, they are stereocilia, which are basically microvilli. We are moving those. By moving those, we open up the channels for sodium and potassium. When we open the channels for sodium and potassium, that will create an action potential. This action potential will create an impulse, and which we will perceive as whether hearing or the balance. Balance in terms of motion, whether we are static or whether we are moving. That makes sense? This is how the gelatinous sepsis of the capula, hair cells with these cilia, stereocilia there, and a kinocilium there. So the movement to and away from the kinocilium, to and away from it, it will open and shut these channels. So the potassium and the sodium will move in and out. Movement of the sodium and potassium in and out is essential for action potential. Okay, that makes sense? Once we generate the action potential, what will happen then? We have the impulses traveling from either the vestibular part or from the cochlear part. So you see that we have the cochlear nerve, which is innervating the cochlea. So this is the cochlear part of the vestibulocochlear, while this nerve is bringing impulses from the vestibular part, which is the hair cells of the vestibular system. What is the important structure of any sensory nerve? Any sensory nerve that you see in the body, what is the most important structure you should see related to that sensory nerve? A ganglion. Excellent. Muhammad Salim, excellent. So we see the ganglion. So we see the ganglion for the vestibular nerve, we call it vestibular ganglion. We see the ganglion of the cochlear nerve sitting in the spiral, in the modulus, which is going spirally. We call it the spiral ganglion. So the peripheral process would go and bring the information from the hair cells, while the central process will go where? The central process of the vestibulocochlear nerve will go where? The central processes of these bipolar are to the brain stem. Which part of the brain stem they will go? At the pontomedullary junction, that's where we will have the nerve sitting, and in the pons we will have these nuclei. Vestibulocochlear nuclei will be sitting there. Now this nerve would be sitting next to which other cranial nerve? Excellent. Through which foramen the vestibulocochlear and seventh nerve are passing? Which foramen of the skull? Internal acoustic. Beautiful. Internal. So if there is any problem at the internal acoustic meatus, it will cause the problems of the seventh and eighth nerve together. Now you can see if there is a problem of the seventh nerve associated along with the problems of the hearing and the balance, you can then think of problem at the internal acoustic meatus, like for instance neuroma. Neuroma, which is compressing at the internal acoustic meatus, will have an upper or a lower motor neuron lesion of the facial nerve. Muhammad Salim said upper, and then Abdullah said lower. Sama is saying lower. Make sure that you understand the difference between an upper and lower motor neuron lesion. So from the nucleus of the facial nerve down towards the effector, which is the muscles of the face and everything, it is the lower part. From the cortex all the way to the nucleus is the upper. So when the nerve is affected, we call it as lower motor. When the nucleus is affected, we call it as lower motor. When it is sitting in the internal acoustic meatus, it will be a lower motor. Now you see that this lower motor will be related to, if there is a neuroma there will be problems of the hearing. Now you can imagine any ototoxic drug which is affecting the electrolytes of our body would have the problems of hearing and balance. Absolutely, Abdullah, it's a Bell's palsy. Yeah, Bell's palsy is the lower motor neuron lesion. Okay, there are different causes. Bell's palsy has different causes. Most of the time it's unknown, but post-viral infection is a commonly known condition. But we are talking about neuroma at the internal acoustic meatus. Okay, does that make sense? Does that make sense to you guys? Because I see only few people talking to me. Now, what else is passing through the internal acoustic meatus? Blood supply, beautiful. Now you can see the blood supply to the inner ear comes from the labyrinthine artery. The other name for the labyrinthine is the internal auditory artery. Same thing. It is coming from the anterior inferior cerebellar artery, or it can come directly from the basilar artery. You don't need to remember all these branches which are further dividing. Obviously, there will be vestibular part and there will be cochlear part. Simple. It's not a rocket science to understand. So, but this artery would be sitting along with these two cranial nerves passing through the internal acoustic meatus. Now, if there is hemangioma, or if there is what you call as aneurysm of this artery, what will happen? If there is an aneurysm of this artery, if there is an aneurysm of this artery at the point of internal acoustic meatus, yeah, that is covered rupture, but before that, it will start impinging on these nerves. Okay, so it will start compressing on these nerves. So we will see the problems of the facial nerve, problems of the balance. That makes sense. So you see, we have a vascular problem, which is seen as problems of the muscles of the face and problems of the hearing and the balance. Does it make sense? Now you must have heard about hearing loss, deafness. Okay, so what could be the causes of the deafness? What could be the causes of the deafness? Many. That's a good one. Many causes of the deafness. Okay. You remember we talked about these bones there, malleus, incus, and stapes. That makes sense now? For instance, if these bones, especially the foot plate of the stapes, if there is a damage to this foot plate because of various reasons, because of some bony problems, this will be fixed. It will not be able to oscillate. If it is not able to oscillate, means whatever is striking on the tympanic membrane, it will not be conducted to the inner ear. So we'll have a deafness. Okay, we'll have deafness. Or if there is a problem of the nerve itself, if there is a problem of the hair cells. So we will have different types of deafnesses. You will learn in your clinical lecture what are the different types of those deafnesses. So we have bone deafness or we have nerve deafness. Okay. Now, what we do when we hear the word cochlear implant? when we hear the word cochlear implant, that's where we put a device outside, behind the ear, and the electrode will pass all the way towards the inner ear, and it will send impulses directly to the inner ear. But if there is a nerve deafness, if the nerve is already gone, obviously there will be nothing which can go from the inner ear to the brainstem. Okay, so that's how the cochlear implants will work. That makes sense? Now, someone asked me about what is the function of the tensor tympani muscle. Tensor palatini muscle on this Eustachian tube. When we swallow, we tense our palate, which goes up, which is this soft palate there, it goes up. When it goes up, it pulls one of the angles of the Eustachian tube. Normally, Eustachian tube remains closed, but when we swallow, we need to open it up. How do we open? We use the same muscle which is helping us to swallow. Okay, that makes sense? This is how the tensor tympani muscle is helping us to open up the Eustachian tube at the time of the swallowing. Otherwise, we'll keep it closed. Okay. All right, I'll stop here. And if you have any questions, please let me know. Make sure that you attend your physiology lecture related to the balance, hearing and balance. Okay. You can write to me if you have any question at any time. All right. I might think of having an extra review session sometime during the evening, and I'll create a Zoom link. I'll send it to you, and if you are interested, please let me know through your class representative. If you are interested, we can always have a review session, maybe sometime during the evening after iftar. Okay. Thank you very much.